is Tony Denuzzo, and I'm in the Department of Internal Medicine and Geriatrics, and I'm director of East Texas Geriatric Education Center. This center is partnered with East Texas AHEC, and they've been invaluable in helping us connect to different locations in East Texas. The GEC is funded by HRSA. We're in our third year. Our funding will be ending June 30th, but never fret. We have a really good renewal proposal in the works, and so we're hoping to send in an expanded geriatric education center that will start most likely in September, and we're expanding to not only other areas of East Texas, but we're going to be doing programs specifically for the UTMB campus and students. And it's going to be a really exciting time to do that. So again, I welcome you, and we have an agenda. You have handouts to look at that you could follow along if you need. We'll be starting with two presentations by Dr. Sarah Toomey-Smith that I'll introduce here in a minute. We'll have a short break. Restrooms we could direct you to if you need. And we will also then have a presentation by me looking at other methods of communicating with patients aside from what Sarah will be talking about. It's really important to have evaluation of what we do so we can get feedback, do improvements, send information to our funding source at HRSA that shows that there is learning going on, you are absorbing information and then using it in your practice. We have a series here. This is a 5-session series on health literacy. We have 2 left. In May, we'll be looking at addressing the needs of special populations. These are Alzheimer's patients we're going to talk about, and also older veterans from the VAs, hospitals. In June, we'll be talking about managing a chaotic healthcare system, and that's like the grand finale of this whole thing. So we're hoping that we'll make some sense of that. And we'll probably introduce, at that point, some issues regarding healthcare reform. I'm pretty sure that'll be a big part of it. In fact, we'll be doing a more extensive program in healthcare reform as part of our GEC proposal that will be starting in January 2011. So there's lots of things to look forward to in terms of what we have planned. Any questions about the programs? It's pretty straightforward, but I'm really glad you're here. Okay. We teleconference to 4 sites, and they may or may be here. We're going to try to make sure they kind of show up. Okay, right now we have Stephen F. Austin in Nacogdoches, down here. Hopefully people will be coming in and out. This is like, who are we going to get? This is Baylor University up here in Waco, kind of coming and going. This is Lamar University in Beaumont. And this is Victoria College in Victoria, Texas. And these represent the 4 AHEC regions and our affiliations that are currently with the East Texas Geriatric Education Center. Hey, Mark, everything okay? This is Mark Scott. He's the AHEC coordinator for Piney Woods AHEC. Let's see, we have up here Amanda. Are you here for in Baylor? Maybe not. Amanda Thomas is our AHEC coordinator for Brazos AHEC in Waco area. Terry Dickerson, she might be in here somewhere, is over at Lamar University in Beaumont, and she's with Coastal AHEC. And then we have Jody Sanders. She's wearing blue, so you really can't see her very well. But don't worry about it. She's there with Victoria College. Okay.
I see blue.
So, there they are. Okay. Welcome you all. When we finish the introduction, if these sites could please mute, and then when there'll be discussion, just unmute, and we'll have some group discussions because we want to hear what you have to say and ask questions. All right, let's get back to the slides. All right. A real feature for all our GEC programs is to offer pre-CE credits. This has been approved, these 3 hours for 3 credit hours for CME, for MDs, DOs, nurse practitioners, and physician assistants. And also we have 0.3 CEUs for social workers. There is on the table a handout for the form, for the attendance form. Please fill this out completely if you are MD, DO, NP, or PA, and also for social work. And then get that back to me, and you'll get your credits, we hope, within 4 to 6 weeks. You get your certificate. Okay, CNE, we offer 3 credit hours for RNs. LVNs will receive a letter of attendance they need. Again, there is a separate form for the CE in this packet for the RNs to fill out. Please fill that out as best you can and get that back to me. And again, within 6 weeks you get the credits. I made one mistake, I'm sorry. The CME is a cumulative certificate, meaning there's a total of 15 hours for this series that you will receive after the last session, which is in June. Okay, so if you attend 5 sessions, for example, you'll get 15-hour certificate for CME after the whole series is over after June. Okay, so, and if you, so on. If you attend 3 sessions, you'll get 9 hours. Things like that. We also offer CE credits for physician assistants and occupational therapists. The main thing for them is, and for everybody, is to fill out the evaluation form. That's also right here. Okay? Lots of paperwork. Don't you love it? Finally, if you're new to the GEC and programming, we have a participant profile form. This is really important because this is where we collect the data in terms of who we reach that participate in our programs. And it's also, your patient population information is very important that we need to report back to HRSA. And we have a data set. I'd like to acknowledge Belengaria with East Texas AHEC, who is helping us with our data set and our data that we receive for all our programs. Okay. Okay. Any questions on the CE? All right. Okay, Sarah Tombs-Smith, I've known her for a long time. She's been here, I don't know, as long as I have. Okay. She's an experienced grant writer, editor, and writing coach with 25 years experience in editing, proposal development, administrative, grant review. Just about everything you could think of that has anything to do with writing, reading, grants. She's our go-to person. She does coaching and grantsmanship, and budget development, time management, that I think I can use with grants going on. Since 1992, she's been instrumental in garnering over $70 million in grant dollars through federal government, municipal, private sources, scientific, pedagogical, artistic, construction projects, you name it. She's done it.
You name it.
She's a real engaging speaker. She's spoken for us for the geriatric lecture before. She's assistant professor at the Department of Internal Medicine and fellow for the Seeley Center on Aging, board certified editor in life sciences, and which is the board of editors in life science. There's a website there that you can even look at. So, there we go. I think we're okay. Thank you.
Okay, thank you, Tony. Yes, in addition to some of the other presentations that you've had on low health literacy and low health literacy in the geriatric population, today we want to just kind of review the groundwork of a little bit of that area, and also want to give you some practical tools that you can use in your daily life to help address this issue, because obviously each one of us can do something. None of us can solve the problem 100%, but each one of us can do a little something in our own venue, in our daily work. Now, as you can see, there's lots of different definitions of what health literacy is. The one that is the most used is the one developed for Healthy People 2010. Health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Now that's a whole lot more than just reading. It's the capacity to obtain, process, and understand basic health information and services. And so in addition to providing this definition, Healthy People 2010 also gives us some goals to shoot for in terms of addressing the literacy, raising the health literacy of populations who are most at risk, and you can probably figure out that you might meet some of those populations in your daily endeavors. And also there's a satisfaction component. Since you'll be filling that out on me later on today, I'm very sensitive to that. So we also want to not just make them more literate, but we want to make them more happy with how we're making them literate, okay? We want to make them feel like they're getting the information that they need and that they're understanding what's being provided to them so that they are able to do what it says there, able to process, obtain, process, and understand the information. And you know there's a lot of information out there for people to obtain, process, and use. There's one other element of the Healthy People 2010 document that I want to point out, and that is that they have identified what constitutes good health communication. So just in case you thought you were giving good information, probably when you read this list, you'll probably decide that you're not. So the Healthy People 2010 is one of the important documents to know about when you understand health literacy, what it is, and how to apply it. There's two more documents. One of these is the Institute of Medicine report on health literacy, which was done in 2004, and this quotation that you see here is probably the most quoted part of the document. I bet Tony will quote it later on today, and I bet the last few speakers have also done so. But it's very startling information when you think about this. Nearly half of all American adults, 90 million people, that was in 2004, so it's undoubtedly more now, have difficulty understanding and using health information, and there is a higher rate of hospitalization and use of emergency services among patients with limited health literacy. So it's an important problem. I think we can call it a problem. Okay, and they said, well, we need to do something. Of course, the Institute of Medicine always has recommendations that go with their reports, and they say that, and in this case, we need to develop, let's see if I can get it from here, programs in order to reduce the effect of low health literacy, and we need to integrate into the curricula at all levels, and this would be a part of that, good health literacy, and also develop materials. And the Centers for Disease Control and Prevention have been a real leader in developing materials, as well as the NIH, and we're going to look at some of those a little later on, that will help increase people's literacy. Now, the reason why the Institute of Medicine issued this report, and the reason why we care about the health literacy of patients or Americans, most of whom at some point or another become patients, is because there's a big burden, a huge burden associated with low health literacy. Why? Because when people don't understand what you're saying to them, when they don't understand, when they cannot process what they are reading, when they can't follow directions, take their medicine, follow the routine, what happens? They get sick more often, they get sicker, and as a health policy issue, we could save a ton of money if we could keep these people from being sicker because they can't understand the information that's out there for them. At this point, I just want to stop for a minute and address the universe in which health literacy lives. There's a lot of other issues that are that are related to health literacy, but they are not health literacy. Of course, one of these is cultural competency, it's not the same thing. Having medical knowledge or having intelligence or being able to read or even having 100% cognitive status, all of those are related to it, but none of those are really health literacy. You can be very intelligent. You can be a very intelligent engineer and not understand, not fully grasp, or not be able to get to the information that you need. Okay, so it's very complex, and I want to set this out so that to acknowledge these other areas, so that you realize. I realize they're out there, but time being short, I can't really talk about those. What I can talk about is health literacy, and how do we know that 90 million Americans have poor health literacy? Well, we know that because of this important, let me go on to the next slide, because of this important survey, which is done about every 10 years. So about every 10 years, the National Assessment of Adult Literacy is done. The last one was done in 2003. There has not been one since then. Okay, and this is a sample, representative sample of adults in the U.S. population are tested to see how literate they are, see if they can read. And when we're talking about reading, we're talking about things like street signs, okay? Really basic stuff. And in the previous assessments, that is before 2003, the people were assessed for their ability to understand prose, a document, and quantitative information, so numbers. Can you read a chart? Can you read a graph? Can you read a map? Stuff like that. In 2003, they added health literacy. As you can see, these are the numbers we care about. As you can see, only 12% have what would be considered proficient. To me, that means like a C, a grade of C. So only 12% of U.S. adults receive a grade of C, B or A, in health literacy. Okay, now what does that really mean? Well, here's some of the sample, sorry, got a few more slides here. Okay, so that doesn't really pertain to the discussion at hand. So proficient is at the bottom and below basic is at the top. So below basic means you can circle the date of a medical appointment on a hospital appointment slip. Basic health literacy means that you can give 2 reasons why someone should be tested for a specific disease based upon a pamphlet. So you're given a pamphlet, you read it, and then you orally give back 2 reasons why a person should have a test. Intermediate would be determine what time a person can take a prescription medication based on the information on the drug level relating to whether they can or can't eat. So, did you see those numbers? Intermediate. Okay, that to me that would be basic. Basically, be able to understand the directions, right, on a medicine bottle. You would kind of want all of your patients to be able to do that, huh? That's intermediate, okay? What? Yes, you would want them to be able to do that, but that represents an intermediate level of health literacy. Yeah, getting scared. Okay, so here's some examples of the kinds of questions that are on that test. For example, refer to the chart, that is the chart to the right, to answer the following question. How many polio vaccinations should children have received by the time they are 7 years old? What's the answer? Okay, right, 4. Okay, good, okay. Okay, you can't answer any more questions. All right. Refer to the, you're going to skew my numbers here. Refer to the X-ray instructions below to answer the following question. What can you drink the morning of your X-ray? Correct. The correct answer is nothing. Now look at the chart at the bottom and look at the people who are below basic, 36% of those answered correctly. That means 2/3 of them did not answer it correctly. 79% of those with basic understanding answered correctly. That means 20% of those did not get it right. Okay, intermediate did pretty good, but remember, intermediate is remember what level of information that represents. Okay, let's look at one more. What does the label say a person should do in case of an overdose? Right, call the poison control center. Okay. Oh, and were you thinking, oh, gee, everybody can answer all of those, right? Those are so easy. Can't everybody do that? Apparently not. Okay.
Yeah, just for eyesight, because if I have to read that, I have to visit my ophthalmologist first.
I am going to get to some of that. Yes, thank you. Later on. Okay. Okay, and you can understand that this might be related to some extent to educational attainment. For example, if you have less than a high school degree, then you're pretty likely to be either below basic or basic. In other words, you're not going to have intermediate knowledge. You're not going to be able to read and comprehend and follow what's on the label for your medication. But this is scary to me. People with some graduate school, 3% of them are below basic. Yeah, this is a representative sample. This is a representative sample of the U.S. population. So. They didn't ask me because I probably would have skewed it down. They probably excluded out doctors. Okay. And
probably you'd be surprised.
It's just some things you don't want to know, like making sausage. Okay, and this is probably the most relevant for our group. Of course, being older means that you are more likely to be on the left-hand side of that scale. So we've got a huge percentage of the population over 65 that's going to score not very well in terms of health literacy. So our older adults have low health literacy. And I should emphasize again, you can see from those examples that it's not just reading, it's not just the ability to write, it's also, you have to do some calculation. Now these are very basic calculations, okay, but you have to be able to calculate, you have to be able to speak, you have to be able to communicate verbally, because if you cannot read something or you cannot understand something, you have to be able to verbally communicate to try to get that information from somebody else, okay? And also the ability to navigate the medical landscape, which I think will be covered in more detail. That involves more than just signage. Being able to find the person and the shop that you need in order to get the result that you need. So. There are a lot of aspects involved in this, and there are also a lot of aspects of health literacy that I would love to keep you here all night and talk to you about, but I won't be able to. And these are some of them. They include web content. There are special rules for designing a web page that people can use. The aspects of designing a document in terms of the size of the font and the amount of white space that you use. I can't really talk about that. The signs that may or may not get you where you need to go in a hospital. And when was the last time you saw somebody lost that you had to tell them where to go? Yeah. When was the last time that you told someone at the hospital how to get to the place where they want to go? The instructions. When was the last time that it involved 2 steps or less? Two directions. Go down the hallway and take a right. How many steps did you need to tell that
person to join the conference?
How many steps did you need? I'll let you handle that. How many steps did you need to tell them verbally to get where they need to go? 4, 5, 6, right? And they didn't write it down. They had to remember it. So you have to remember, how much information is that to remember? How likely is it they got where they were going? How many times did they have to ask for directions between the time they got lost and the time they got where they needed to go? And also just translating, there's a whole body of knowledge about translating into other languages. So we don't want to, can't talk about that today. Okay, so as you can see, your older, your geriatric patients have are more likely to have low health literacy. And because part of that is because of, in addition to the other risk factors that they might have, like literacy, like maybe not finishing high school. They are also likely to have problems with being able to see or being able to hear. They have slower brain processing time, and I should also mention not just older adults, but you know, if you have reduced cognition for any reason at all, and let's just exclude all of those who might have some form of dementia. What if you're stressed? What if you're depressed? What if you're sick? Okay, and each one of those puts up a barrier to your being able to understand. Right, and how many patients do you see that have one or more of these barriers? Yeah, pretty much 150% of them. Right. Okay. And you know, patients are very clever. They will not come up to you and say, "I have low health literacy. Please help me." Okay. They're going to do right. They're going to do other kinds of things. They're going to be sneaky. They don't want you to know that they don't know, that they can't comprehend. So this presents another barrier, not to the patient, but to you, because you can't always identify easily low health literacy. So how many times have you run into a situation where you will tell someone something and they'll, here, read this, and they'll say, "Oh, I forgot my glasses. I didn't bring my glasses with me." Or, "I'll fill this out later." Okay? Or, my favorite, "Do you have any questions?" No, no questions. What does that mean? What you really want to say when you're saying, "Do you have any questions?" what you really want to say is, "What part of this information did you not get?" "I didn't get any of it, but you're the doctor, so I'm just going to go home now." Okay, so they're just going to agree with you, right? So you don't ask a yes or no question because you're not asking the appropriate question to get the response that you need. And the response that you need is, what is it that you don't understand about this, or what of the information do you not grasp, understand, and are able to use, right? Okay, so your patients are, they're embarrassed. They don't want to admit that they don't understand. You're an authority figure, okay? This goes to part of the cultural thing, okay? You don't want to take up too much of that person's time, and so you're just going to make it easy for the healthcare provider and just smile and nod and go on your way. So how do you counter that? How do you counter that? Okay, you need to ask questions that are not yes or no questions. You need to ask open-ended questions. Okay, tell me about the problem. Tell me why you're here today. Tell me how you've been feeling. Okay, and the best thing that you can do is get them to teach you back whatever it is that you have told the person. So say something like, "Okay, after you leave here today, what are you going to do?" And they'll tell you, gave them 5 steps, and they give you back 2. You say, "Okay, that's great." You always, whenever you do that, whenever you ask them a question and they respond, you always give a positive response. You always give even if it's completely wrong, do this with students too, even if it's completely wrong, even if the answer is completely wrong, that's a good try. Then you give them the correct answer. Okay? Why? Because you want to lower the negative threshold that stands between the person and the information. Okay, and I have as your first handout. I have no connection with this company except that they're on the internet, and I went on the internet and got this. Here's a nice handout that you can you can make copies of and pass them around. 6 steps to improving patients' understanding. And this covers some of the points that I've already made. Now, in addition to the fact that we will save money if we have less low literacy, if we have more better health literacy, people are going to be healthier with better health literacy. Okay, and there's a whole bunch of research that's been done on this. I'm just going to present a few of these. Okay, these are a lot of these are in the Institute of Medicine report. Okay, if your health literacy is low, you're going to report poor health status. So you're going to feel that you are less healthy. And you're going to be less likely to use preventative care. And that's what we want people to do, right? We want to head things off at the pass. Before you get sick, we want you to do things that keep you healthy. And these people are less likely to do that. They're more likely to be hospitalized and their outcomes are poorer. They're going to be in the hospital longer. Everything is going to cost more, and all of that adds up, right? They're not going to follow through on whatever it is that you told them to do. So now you know that it's a problem. But the question is, what can you do on a practical level to combat low health literacy? And there's 5 basic steps. Okay, 5 basic steps that you can take, say, for a piece of documentation to be able to address low health literacy. That is, first you need to identify the readability level. Can the person understand it because it is presented into complicated a fashion? Not that the information is complex. People can understand, even people with low health literacy can understand complex information, but it must be presented in a way that is accessible to them. Use plain language, and I'm going to talk later on about what that is. Define the terms, layer the information, and finally get feedback. Okay, appropriate feedback. Okay, now it's time for handout number 2, which is a 2-page. I guess these are back and front. So it's the next 2 pages. It's just pages of text. The next 2 pages of your handout are what we are going to use, and we're going to break up into groups to do this next exercise. There's a lot of different situations in which a person, maybe you won't be amending a text, changing an insurance form, but you might have to help a patient navigate some of this stuff. And each one of these, any one of these different items is daunting in itself. But then when you put those all together, you have a lot of challenges that people have, and so. Maybe, in other words, what I'm trying to say is you may not be changing the document, but you can help interpret the document. So even though these are writing strategies, you can use them to verbally help patients be able to access the information. Okay, and so the second one on that list is plain language. And plain language does not mean dumbing down. You can have the same amount of information in a dense, complex, difficult piece of prose as you have in a simple piece of prose that's easy for a person to understand. What is important is clear writing, effective organization, and good presentation. We won't be talking about the presentation, but the other 2 we will. Okay, so you can tell people, to establish eligibility for a grant, an applicant must show that the applicant is an Indian and that the present housing of the applicant is substandard and inadequate. Or you can say, to establish eligibility for a grant, you must show that you are an Indian and that your present housing is substandard and inadequate. I believe this is a Canadian example. So you can see that the second example is clear and direct and it also uses fewer words. So as a rule of thumb, like a readability index, if your sentence has fewer words and says the same thing, it's probably a better sentence. Okay, here's another example. If the state secretary finds that an individual has received a payment to which the individual was not entitled, whether or not the payment was due to the individual's fault or to misrepresentation, the individual shall be liable to repay to the state the total sum of the payment to which the individual was not entitled. Are you asleep yet? Okay, good. Or you could say, if the state agency finds that you received a payment to which you were not entitled, you must pay back the entire sum. So the purpose of plain language, notice these both say the same thing. And on these plain language examples, each one is set up like that. They say exactly the same thing, the same amount of information, but just stated in a way that the reader, oops, sorry, I meant to point. In a way that the reader can find the information and understand the information. Okay, that's the purpose, that's the goal of plain language. So to help the reader find the information and understand it. Okay, and the best way to do that in any kind of writing, whether it's for low health literacy or any kind of writing, is to think about the reader, think about who the reader is and what the reader needs. Okay, because after all, when you think about it, writing is supposed to be communication. Communication doesn't just mean I write it down and I feel good about it. That means that I write down something and it goes from my brain to your brain. I write something that I understand and then hopefully I understand it, and then you understand it after you read what I wrote. So if you can think about who the reader is and what their needs are, and use the writing to address those needs, to answer those needs. That is the essence of plain language, and it's the essence of good writing. It's thinking about the reader and putting yourself in the reader's place, which is probably the hardest thing there is. Okay, something happened to that, and just in general, use non-technical language. Okay, that's why we count words with 3 or more syllables. Can you make that into a word that people commonly use? And in any kind of professional endeavor, and medicine is certainly one of those, we have a lot of jargon, technical words, little letters put together to make up words that we know what that means. It just saves us time during the day. But people who wander in off the street, they don't understand what those terms mean, or they don't understand. Sometimes they understand the term, but they don't understand all of the connotations that you have attached to the word. So that's another point to remember, is that within a given context, within the context that you work professionally, you may have connotations, that is, meanings attached to that word, emotional or otherwise, that the other person does not share. And so you think you're communicating something that they don't know. Did you have a comment?
Well, I was just going to say, would you agree that, I mean, I certainly agree with everything that you're saying, but I would also think part of the problem is our litigious society. So if you have information on a pill bottle, you want to cover all your bases or somebody can come back and sue you. If you're going to sign a consent for surgery, you want to cover all the bases of what could possibly happen. I mean, so a lot of times you feel like you have to go overboard for legal purposes.
Well, the answer to that dilemma is to layer the information so that you can present all of the information, but you present it in such a way that that people can access it as they need it. So I understand what you're saying, but in general, when you're explaining an instruction sheet or helping someone understand some other information that they were given, or they have all their pills with them and you help them kind of make sense of what they're going to do with all of these, okay, then you want to give the bullet points first and then say, and then later on you can read this, or you also need to know that. So yes, I agree with you that I mean, on the one hand, you know, all I really need to know today is that I take this pill 3 times a day. But legally, you have to give me this piece of paper that lists the 15 or 20 or 35 different ways that this thing could injure me. So I think it's being able to, and there's another, it's being able to sift through the information and tell what's important and what's not important. There's another aspect of that, not just the legal information that we're required to give, but there's also different competing bits of information on television, on the internet, from your friends, from your children. You get all these other sources of information. A lot of times they don't agree, and so people are confused by that, and they have difficulty knowing which information should come first. Because after all, I mean, you know, I was watching Wheel of Fortune, and this guy that looked like a doctor came on and said something, and so I just figured, you know, that's what I was supposed to do. Okay, so use the personal pronouns, use the active voice, make things shorter, and layer the information. Okay, so there are 7 steps. So you say, well, how do I really do that? Well, there's actually a little process that you can follow. Here it is, 7 steps to writing plainly. Number 1, place the subject early in the sentence. These may sound really obvious. If they were obvious, I'd be out of a job. So, if deciduous and evergreen trees experience yet another year of drought like the one observed in 1997, the entire Sandia Mountain ecosystem will be heavily damaged. Okay, what's wrong with this sentence? I just have to wait. How many words is it before I get to the comma and I get to what the sentence is really about? So what happens to the reader when they have to wait all of this time and hold all of this information before they get to the main point? They're completely distracted. There's not, you know, it's like trying to drive and talk on the phone and listen to the radio and yell at the guy down the street and, you know, eat your lunch. And, you know, it's too many things. So you need to, in most cases, you can vary sentences, it's okay. But in general, put the subject and put what the subject does right up front so that I get what a friend of mine calls the clothesline. So you get the most important thing, and then you can hang stuff on the clothesline as you go along. That's what you want people to do with the information that you give them. Give them the most important thing and then have stuff to hang on it. If you do it the other way around, they can't, after I've finished the sentence in that first example, now I have to stop and figure out what it meant, and now I have to put the information together after I've read it. Oh, sorry, I didn't mean to do that. Okay, so the entire Sandia Mountain ecosystem will be heavily damaged. Oh, this is not good. Now I'm going to put something on that clothesline. If the trees experience another year of drought. Also, you will notice that there are, there's 2 subject, trees experience and 1 observed. There's 2 subject-verb constructs before you get to the main clause. That's very, very, I mean, not only is this a long sentence, it's complicated. It's unnecessarily complicated. Okay, once you put the subject at the beginning of the sentence, whatever the subject is doing, put that right next to it so the reader can find it. The figures support our theories. The questionnaire, well, what does it do? Because the reader naturally wants to know. Now you've given me the subject, I need to know what it does. There's no point to make me wait with a whole lot of other words before you actually get to what the thing does. What that does is frustrate, and remember we talked about the geriatric population, right? They have all those other complications in there, all those other risk factors. Maybe they're sick or depressed, or you know, they have other things that are getting in their way. So you're just putting too much onto something that's already overloaded. Okay, another thing that people do a lot is they put a lot of prepositional phrases into the sentence, and you can take some of those out. These are bolded so you can see them, but here's the first sentence. The decline in the number of businesses owned by locals in the town of Socorro is a demonstration of the increasing hardship faced in rural communities in the Southwest. And now you say, okay, read that back to me. Tell me what I just said. They say, let's say, yes, doctor, I got it all. Socorro's declining number of locally owned businesses demonstrates the increased hardship faced by southwestern rural communities. Notice also there's fewer prepositional phrases and it's a shorter sentence, right? And number demonstrates. And here we have decline is. So you see that in the second sentence, we have an active verb. In other words, it demonstrates is more active than is, right? Demonstrates means shows. Okay, let's look at another one. The report of the Secretary of Labor was comprised of a list of essential skills needed by graduates of public schools in America. Or you could say the Secretary of Labor's report listed essential skills for American public school graduates. Oh, ever so much nicer. Okay. How many times have you run across a sentence like this? The necessity for the new process came from the unreliability of the current process. Why do people even write sentences like this? I think they write them because it sounds so smart. It sounds so intelligent. But you know, it's probably a little more intelligent to say a new process was needed because the current one was unreliable. Or we needed a new process to replace the current unreliable one. Or you could even, now that it's shorter, we could put a little more information in there. A new process was needed because the current one failed 47% of the time. Get a little more information in there because now you got room. Okay, uniformity will be much better across the lab once implementation of the new process is complete. If I could just get rid of the word implementation and never hear it again, I'd be happy. The lab will be more uniform once the new process is in place. Just get rid of that. Okay, wordy phrases. These are my favorite. Instead of saying at this point in time, just say now. In the near future, just say soon. Due to the fact that, oh, how many times have I crossed that out in my long history on this planet? Just say because. In the event that, you mean if? In the modern world of today, or my favorite, in order to test. What does in order add to that sentence? Nothing. So get rid of it. Blue in color. Okay. You say, well, that's pretty easy. You know, cool in temperature. Join together. Yeah, when you join them, they're together. Okay. My personal opinion. Well, okay, if it's your opinion, then it's probably pretty personal to you. The reason is because. Just because. Repeat again. If I repeat it, I will be doing it again. Okay? July always is a month, so you don't have to say the month of July. Okay? This sounds really stupid, but people do this all the time.
No, some people's name are months of the year. April. People name their kids month of the year. I've seen people call it April.
But if your sentence says in July, we saw. But probably the context of the sentence will tell you that it is a month and not a person.
Then during wedding, you always say that what men has joined together, what something has joined together, let no man put asunder. So that's really superfluous.
It is superfluous. Yeah, you could just say they're married, don't mess with it, and then just have everybody go home. Right.
What God has joined together, let nobody.
That's right. And then he could say, it is finished and completed. Okay. And then we all go out to the, we all go out and have a nice party. Okay, so saying more words is not necessarily better. As you can see, the Pythagorean theorem is 24 words. The Gettysburg Address is 286. And the U.S. government regulations on the sale of cabbage is 26,911 words. On the sale of cabbage, it's not even broccoli. On the sale of cabbage. Okay, oops. So if it's, if it's short, it just might be more, more significant. Okay. We're almost there. Step number 6. People breathe when they read. It's the same thing as speaking. So you don't want to have a sentence so long that you asphyxiate the reader. Here's a good example. Researchers in several fields have stressed the importance of agglomeration in crystallization due to its enabling of control over crystal size and solution, which in turn can serve the interests of industrial partners like manufacturers of fertilizer, whose products need to meet certain particle size standards. Okay, researchers in several fields have stressed the importance of agglomeration in crystallization. Agglomeration enables control over crystal size and solution. And this effect interests industrial partners like fertilizer manufacturers, whose product must meet certain particle size standards. I think the sentence, it can even be improved over that, but you see the point. Even just breaking it at one place makes a huge difference in your ability to really kind of get your mind around that information and swallow it. Okay, and then finally, how many times have you read something like this? First, we ran the final assay. Next, we collected the results. Third, we wrote up the results. Lastly, we reported them to the executive committee. The study was approved for phase 2. Or you could kind of put some of them together. Vary the sentence rhythm, have a little bit of interest in there. It doesn't all have to be dry and boring. After running the final essay, we collected and wrote up the results. If you have a subject that's in 2 sentences, you could put the 2 verbs together. The executive committee approved our study for phase 2 after reading our report. Okay, and so you notice here what they did was they put together the subjects that were similar. We did these 3 things, and then here we reported to the committee and it was approved. Well, you see what the committee did is actually made into a separate sentence here. So the logic of the sentence better fits what actually happened within the text. Okay, let's go to the next thing. Now you're still not done. You did the 2 hard things, but there's 3 more things to do. If you have something that a person has difficulty reading, you need to be aware. Remember those big $3 words? You need to be aware that sometimes terms are going to have to be defined by you. So what does that mean? Did you know there was this site here, NIHseniorhealth.gov? I didn't know about that before. I put it in here so that you could go there at your leisure. It's very much like Medscape, which you may be familiar with, but this is just for seniors. And it's very user-friendly, and it's got some little buttons up here that allow you to. It comes in about this size type, but you can make it bigger. You just kind of press the plus button, and it gets bigger and bigger and bigger. The text gets bigger. It doesn't have a whole lot of extra stuff that you see on other websites, stuff going down the side. It's fairly simple, but you can still get to all the information. Okay, so a good place to look for some terms that are defined would be this web page. And here's a nice example. When you define a term, okay, when someone says, "I don't understand this word," what is a definition? What does it mean to define that word? Do you even know? Oh, you don't know. Maybe you forgot from when you were in college, or maybe your college English teacher never told you what a definition was. Well, I'm here to help you. A definition of a term is the term, and then the equal sign. In a definition, we call that is, the class to which that word belongs, and the characteristics of it. Here's an example. Medicare is the U.S. government's health insurance program for people age 65 or older. So Medicare is the term, is the equal sign. Okay, and what is it? It is a health insurance program. That is the class to which it belongs. What kind of health insurance program? One of the U.S. government and for people age 65 or older. Okay, notice that Medicare, the term Medicare, is not used in the definition. You can't define the word by itself. Okay, Because if you do that, you didn't really help the person that you were supposed to be helping. Okay, here's another example, again from the same website. These are some frequently asked questions. What is integrative medicine? Please, I need the definition. Integrative medicine is a total approach to care. I can't use medicine in my definition. A total approach to care that, and then you have to say that integrates, that combines, because integrative is a big word, so they made it smaller, combines standard medical treatment with CAM. And what is CAM? Oh, it's up here, complementary and alternative medicine practices that have shown the most promise. And then this is from this section here. So there's a whole bunch, your next question that you're likely to ask was going to be number 4 in the list of questions. Okay, that's part of what makes that such a nice site to go to. And okay, so you see what it means to define the term. You give the class of what it is, and then you give the characteristics within that class. It is a type of thing. Okay, what is a Camaro? It is a type of sports car made by so on so. Okay, good. I should have some more definitions, but maybe I will later on. Okay, layer the information. I've mentioned this before. What does that mean? That means that when you give a whole lot of information, you have to indicate within the information what is most important, what I need to know right now, what is less important. I need to know it, but I can't get to it right now, and what is even less important. Because people want, and this includes older patients, they want to have a comprehensive understanding, but they cannot take it all in all at once. Okay, so they need to be able to identify what is the most important, what is less important, and what is nice to know, but I don't really need to know it. So this is a really nice example of layering information. First you have the term, and you have the definition, and then you have the most important information after that, right? So first I define the term, and then I talk about the 4 parts, Part A, Part B, Part C, Part D. Then I also have, it says start here, Medicare and You 2010, Medicare Program General Information. So if I need more information than that, I can go to these other pages which have more information. I can also go to related topics, financial assistance, health insurance, Medicare prescription drug coverage, and so on. I can also go here. I can get Medicare updates by email. What does that mean? Well, you can click on this. It says, what's this? Right? So you see how they have layered the information onto this page so that a person who has a question, what is Medicare, and then the other questions that are going to come after that are also, if they're not addressed here, you can get to them. Okay, you can find them. Impressive, isn't it? Yeah, it is very impressive. Okay, and then finally, in the process, get feedback. When you're writing something, you're writing a brochure or something, you might want to have a focus group of people from the audience to which it is directed. If you're explaining a piece of paper to a patient, then you look at the cues that you're getting. Also, one of these documents that I brought with me, I'm sorry you can't all see it. This is talks about the health literacy environment of hospitals. And one of these pictures has the guy that's being spoken to. He's sitting in a wheelchair, and these 2 people in white coats are standing on either side of him, talking across him. So he's down there, and they're talking down to him. Okay, I think the information's going this way, and it's way up here at the surface of the water, and he's down there, right? So you need to get at the level of the person that you're talking to. Be on their level. Look at their physical, the way they're sitting. Is the way that they're sitting saying, I'm full, I can't take any more right now, so I need to stop and give it to them to take home. Point out the things that they can look at next and give it to them to take home. What about your body language? Is your body language saying, I'm busy, I got 1,000 other things to do, I really can't do this right now? Or is it saying, I need to, or is it a helpful kind of a thing? Okay. And again, ask them to tell you, okay, what are you going to do now? Okay, what's the most important thing about this? So get them to tell you what you think they need to know, so that you can test to see how much they've taken in a non-threatening way, of course. Okay, now we come to the next part of today's presentation, or today's thing. Okay, and yes, and this starts with the 7 pages that begin with 2009 H1N1 flu, swine flu, and you. So I think most of the groups just have enough people for one, most sites just have enough people for one group. Okay, I think we have enough for 2 groups here. So in your group, I want you to pick one person to be the patient and one person to be the healthcare provider. And you can make that person whatever kind of provider you want to make within your group. Just repeating what I've said before, patients have a lot of things coming at them, and sometimes the information is very complicated and sometimes contradictory. 88% or more, probably more, right, may have low health literacy, and there's different levels upon which you can address this. Okay, you can also train others in addressing low health literacy, or just if they are not aware that it exists, teaching them about that. If you are making some new materials, you might integrate the concepts into those. Work on the institutional level, and this would include some other things like signage and documents that are made at the institutional level, or test websites to see how useful, how accessible the information really is. Because the point is that we have a lot of information, and we want to share it with patients, because information, right? Knowledge is power. The information allows them to do things that they couldn't do without the information. So just want to recognize that there's things that you can do besides translating documents, besides being aware, helping the patients directly and indirectly in order to address this very important area that we have. I have included for you at the end of the PowerPoint some of the most important documents on this in this topic: the AHRQ report, the others that I have mentioned, and then finally I would direct you to the HRSA page. I'm sorry about how these things kind of came out here at the bottom, but really, the CDC, as I said before, has been very proactive in developing beautiful web pages and other very accessible information for patients and for people. And they developed a very nice continuing education module, which has now kind of shifted over to HRSA, and it's completely free. And it's online, so if you want to pursue this topic further, and you can, you also, oh, sorry about that. You also get some nice credits for that. Then that is also available. And any of these documents have huge, enormous bibliographies where you will be just completely overwhelmed with all the other information that's out there. Okay.
All right.
I'm done. That's me.
Thank you very much.
Thank you.
All right. Sarah provided all this information in terms of writing skills and reading levels, and obviously there's different ways of communicating. We're in an area where we have communication and information being bombarded to us all the time. We're in a high technology. We got to use, when we put a grant in for education, we got to make sure that we provide the means for technology to be a part of how we're going to do education activities. Learners don't just learn from being in a room and being talked to. We have lots of different ways that we're going to be using to convey information. And it's the same type of thing for conveying information to patients. Obviously, there's more than one way to do it. You just don't talk with them face to face, although that might, has been shown to be the most effective and maybe the most common way to communicate with patients. But human beings, we're hardwired, for listening. Somehow we want to hear that information, but we want to be able to comprehend it. We want to be able to take it in and know what it means, and then we got to know how to use it. And everything that Sarah was talking about, that's one way to do it. But I'm going to be talking about several other ways that rely on video, audio, and then a combination of video and audio. Okay. So just two real simple objectives. Let's just going to go through some different types of methods in which we can communicate with patients, and I'm going to ask a question here in a minute, and then there are some guidelines needed for appropriate media use. We got to make sure that we provide the means for technology to be a part of how we're going to do education activities. Learners don't just learn from being in a room and being talked to. We have lots of different ways that we're going to be using to convey information. And it's the same type of thing for conveying information to patients. Obviously, there's more than one way to do it. You just don't talk with them face to face, although that might, has been shown to be the most effective and maybe the most common way to communicate with patients. But human beings, we're hardwired, for listening. Somehow we want to hear that information, but we want to be able to comprehend it. We want to be able to take it in and know what it means, and then we got to know how to use it. And everything that Sarah was talking about, that's one way to do it. But I'm going to be talking about several other ways that rely on video, audio, and then a combination of video and audio. Okay. So just two real simple objectives. Let's just going to go through some different types of methods in which we can communicate with patients, and I'm going to ask a question here in a minute, and then there are some guidelines needed for appropriate media use. And maybe a call is returned, maybe not. Okay, so that right there may be some communication issues that have to be taken care of. So and then they come into the clinic. All right, they go to the desk. All right, say, I'm just doing one little scenario here. Help me out with what really happens, because I'm not there. And so then they fill out forms. All right, they ask why they're there. They get in the waiting room, and then they go and maybe to fill out everything they need, and then they get to see who they need to see. And a lot of times when I've gone, when I see my PCP, someone will come in, most likely not my PCP, maybe a resident, somebody else that I don't know. And so we're talking and discussing what the issues are. When we get an idea of maybe something is needed, I will not only be told what to do, but a lot of times I'm given information, something to be printed out. I had a busted eardrum, so my tympanic membrane was going bananas. So I had to figure out, okay, here's some information in terms of treatment and what it all means in terms of what I needed to do to get that cleared up over a short period of time. So there wasn't a lot of different ways of talking. We were talking, we were shown some information. I nodded, yeah, I understand. I talked back a little bit, and everything seemed to be fine. But there wasn't a lot. I mean, and I didn't have a hearing. Well, at that time, I did have a hearing problem, so I had to make sure I was be able to hear what was being said. But usually, I don't. I don't have vision problems. Well, starting, age. But so I was able to see the materials that were given to me, and I think I could understand, instructions pretty well. But we're talking about older patients. How do you do it? What else do you use if you're with, communicating information to an older patient, for example? Does anybody do anything different
Sometimes
than
just
that?
drawing something out, like you're trying to show how medication works, when it's released, and when it's kind of doing a graph, then doing a visual like that is helpful.
You really do that. You take, that's And they, how do you initiate that? Do you ask like, I'm going to show this and tell me if this is helpful or something like that, or?
The patient will ask, well, how does this med work and how is this med different? And showing how the peak and troughs of the meds and how the two medications may be the same, but how their, release affects their disease process. And so they see the visualization. You can watch, like you said, their body language,
Right.
their follow-up questions, just whether they're getting it or not. Simple question of, so, why do you take this one? What does this med do for you?
Right.
So, it's one thing.
And so and then it follows up with, okay, and when you have to take this, this is how you do it. Here are the instructions, and this is like on the bottle, everything you need to do, and you're on your way. Okay. Well, I'm going to show. I really like these ideas. Is that along with some of that audio thing, I'm going to show something called a pill card. If you've ever used that and how you construct a pill card, it's pretty neat. I mean, I think that's going to be, hopefully, a little helpful. Well, I'm not going to worry about it. So, anybody have anything else regarding working with patients and communication? Yeah, Patty?
I use a lot of demonstrating something to them and then having them demonstrate it back to me, not just telling them because you
Right.
don't know what they understand, and even if they're telling you the truth, if they're giving you the right response.
Right. You see, and that's something, Sarah mentioned that a little bit in terms of some of the barriers to the communication with especially with an older patient. If they can't read or they can't see real well, there's a certain level of embarrassment maybe or shame. They may not disclose that. So that's been something that's been very common. Yeah, Karen?
I do a lot of telephone triage with our surgical patients, so I need to make sure that they understand the directions, or I'll say,
Right.
what did doctor tell you? It's nice now in Epic, I can pull that up and, read kind of what the doctor told them as the patient's telling me back, and if need be, correct or help them understand a little bit better. And a lot of times I have to say to them, now, tell me again what we just talked about in an appropriate manner so that I
Right.
know for sure they did understand it.
And with the amount of time that you have, that must be a real challenge to get that in. 6 minutes worth, right. Okay. I wanted to just bring up the other sites. Over in Lamar, is there any other ways of communication that maybe that you work with your patients? Any different types do you show them information, for example, on, besides telephone, follow-up, talk back, draw pictures? Do we get on the laptop? Do we look at information on the internet, for example? Anybody have anything else they want to share? All right, so I'm going to go through and just show you. Just a lot of this is pretty much, I don't think anything's going to be that new. All right, but in terms of verbal communication, it's been shown to be probably, the most ideal. There's a lot. We mentioned body language. When you're with somebody, whether it's face to face and you talk with them, you can kind of get an idea of whether or not they're actually getting it. I love seeing the nod of heads. That's so valuable. That's the best way. And so, the tone of voice is also very important. I have a tendency, and there's things you don't even think about, with verbal communication. I have a tendency, after a while, I don't know, maybe I just run out of gas, and I'm like, my voice just starts getting a bit lower, and I don't even realize I'm doing it. It just gets, and everybody then they're just like, what is he saying? So, and I'm trying to remember that, and it's hard to do that all the time because I'm just tailing off somehow, but that's just, so, you could have that verbal communication, and hopefully that person will be there, but what if a face-to-face isn't always the option? What do we do in those cases? So we mentioned the telephone. All right, it's a telephone-based system. In terms of when I get an appointment, I always get the recording. Somehow discussion we could talk. Can you please mute? I'm not sure where it's coming from. Maybe it's Lamar. I'm sorry. We're going to have time for some discussion if you'd like. Okay, I'm sorry, thank you. Yeah,
Hey,
this,
Tony, they're just trying to tell you we can't understand you. Well, it's Amanda.
well, okay. Is it the volume or is it just, is
No,
it?
you're not talking into the mic or something?
I'm all wired. Thanks, thank you, Amanda, I'm sorry.
No problem.
That might help. Does that help? Amanda, is that better?
Yeah, that's better. Thank you.
Okay, you're welcome. I'm looking at the speakers in the ceiling. I don't think, okay, well, anyway, I'm sorry about that. All right, so video phones being pretty sophisticated. Like I said, I don't know anybody that uses them, but there was a lot of information that they were very, very helpful in terms of getting information across to different groups. But I wouldn't rely on them a whole lot. We have a lot in terms of interactive telemedicine going on, obviously for areas that have access issues. You know, we obviously with the prisoner system, TDCJ, and with rural communities for sure. Telemedicine is valuable. I have some grant I'm writing in terms of doing increased video conferencing and telemedicine, and we have like, gosh, I don't know, about over 3,000 telemedicine encounters per month. You know, here. I mean, but it's a large area. I mean, this isn't just going to one or two places. It's a large network for telemedicine. So we're using that more and more. But I think with all of these, you have to be a little careful in terms of assessing whether or not they're limited. There's certain things that you can work with telemedicine in terms of doing some blood pressure testing. I think there's some general information you can get with a patient. There's probably some other tests that you can do through telemedicine, but it is pretty limiting. Okay. The audio communication then, all right, so we have this thing with appointments, pre-recorded messages. You could do phone surveys. You could do it's really easy to do a follow-up by phone, you know, if you can get hold of the person. You know, so you get their landline, you get their cell phone, you get their BlackBerry, you get their work phone, you get everything you can, and maybe something will get through. In terms of audio tape messages, that's, again, you have to bridge the technology. All right, they're nice to make. You know, you get a tape, you know, you give it to a patient. Do they have the means to play it? All right, it could on a DVD or VHS or something, if anybody uses VHS anymore. You know, so those can be developed in terms of getting information, but again, it's a matter of whether or not they have access to that equipment. Anything else you want to add for audio communication?
The other thing that I find a lot of times patients are to leave a number where we can call them back at.
Right.
And you'll do that, and unfortunately, we don't always think about people knowing how to use that piece of equipment. A lot of times, and it kind of sometimes seems to be the elderly, I'll call them back and they're not there, so I dig around a while and find another number to reach them at. And I said, well, now the number you gave me, was that a good number? Oh, yeah, that's my cell phone. Oh, whoops, I've had it turned off. I didn't know that. So little
Right,
things
right.
like that can sometimes waste a lot of precious time, and just ways to know that might just happen.
Right.
Or when I'm first calling people and I don't know they're on their cell phone, a lot of times you can tell where people are at if they're driving or things like that. But to ask them, did I catch you at a good time?
Right.
So people can say, not really. Or I'll say, do you have a pen and paper handy? No, I'm driving down I-45. Okay, you call me back then. Or I'll call them back and leave them a number they can call me back at, and they'll just let it go to voicemail.
What if you get, how reliable, that's a great point here, I appreciate that, but how reliable is it if instead, you call and you get a patient's family member, and you got to leave a message to the family member to get back to the patient somehow, and getting back, I would imagine that's a barrier. That it may not, right, it's pretty unlikely that it'll actually get through, and that the information, right. So with those kinds of situations, do you try to find out how to contact the person from, directly if you get a family member?
For another number, or call them back the next day is what usually happens. They'll say, oh
Right.
yeah, I'll give grandma the message or whatever. And
Right.
so I just return the call the next day or keep trying to get a hold of them, hope I reach them.
And I've often wondered how many fall, through the cracks for the most part, on a follow-up especially. If there's something that needs to be followed up on with information, how often do you do it? And then until you say, well, I'm not getting through and I can't find the person. So anyway, but there's definitely drawbacks. You can do the best you can. It's really what I felt it comes down to. But it is an alternative way to get some of that information. Okay. Visual. Now this is great because this is something that it could be really kind of creative. The thing is, how do you use all of these, the pictographs? They've been doing pictographs since, I guess, a long time ago, on the cave walls, So those are out there. And I'm sure that you could probably depict a certain, whether, a lot of times being used for medication is probably the most common way, like that we've used the pill cards, for example. But these symbols are out there. The thing is, are they universal? And there actually is a group for universal, the U.S. Pharmacopoeia, the USP. They have over-the-counter medication symbols. I have this if you ever want to take a look at it. And here I am again. Put it in my pocket. These are pretty universal, and it's if you've seen these have been approved with the U.S. Let me see. It's the approved by Standard Setting Authority in the U.S. Department of Health and Human Services. So these things are, they're supposed to depict something that we all know when we see the crossbones, skull and crossbones. That's not good. That's not good. That's poison. Like that. I like this one. Do not add salt. You have a salt shaker with a big X to it. And this one is pretty interesting with the symbol of do not shake. It has this thing with, and there's like these little lines around it with an X across it. And some of those may actually work, but I have a way of showing something in terms of pictographs that that might be a little easier to look at. Speaking of getting information out there, do you know what would happen if FedEx merged with UPS? They'd be fed up. All right. So, pill card exercise. You all have this handout? Okay. I'm actually going to reduce this. Okay. Yeah, we're going to do an exercise. Okay. One more. Oh. Yeah? That sounds great. Hey, what's going on? What?
They can't see the
PowerPoint. The camera is not.
Okay. Let me fix that. You see, this is the disadvantage. See, this is great. Well, this is disadvantage of not only having to give the talk, but figure out how to use all these things. But no excuses. I should have kept up with it. I'm sorry about that. Let me see where I am here. Okay. There we are. We're back. Thank you. All right. So this thing, I think, is pretty neat. I mean, it looks at these kinds of symbols that you can make a chart. And you could work with the patients in terms of developing this. I'm just going to go through the different steps. It's really pretty easy to use. And I could send it, if you like, as a Word document, which is on there. Because these symbols, I mean, like the way I did it with this is, I just put them in here and I just kind of cut and pasted them, and so they're right there. Okay, so let me just go through this real quick. This is what you'll need, in terms of printing, and but it's really used. It not only shows the kind of medicine, shows what it's used for, the amount of dose, and how often you need to take it. So first thing you would do is you would just make this table, and this is the general format for the table with the patient's name. It's good to put the pharmacy number on there, even where the pharmacist might be located. If there are several, you can put that in as well, and then the date that this was done. Notice the symbols used to take, for when the medicine is taken, morning, afternoon, evening, or night. And next thing you do is fill in the information and the med info. All right, so here we have simvastatin, which is for cholesterol use, taken 2 pills at night. You also have insulin, diabetes and sugar, injected 24 units before breakfast and 12 units before dinner. How's that going to look on the chart to make it easier if a person has a hard time either remembering or being able to understand or reading this information? Well, it could look like this. All right, and you could do this right there in the office, in the clinic, with the patient possibly, if you have the computer set up and the little symbols, and print it out. Give them a couple copies, put one on the fridge, put one in the car. Nice big print, 8 by 11, at least, in color. In color is very important. And these symbols are very basic. Here's the pill shape. It's kind of oval, and you take 2 at night of the simvastatin. Okay. The insulin is injected. That's a sugar bag, if you were wondering. All right. And it's one is at 24 units before breakfast in the morning, and 12 units before dinner or in the evening. Okay. Now you might be able to do different types of symbols. This could be expanded as far as, well, what about getting the information before or after breakfast? That might be a little more difficult. Can you expand some of this? There's all kinds of different things you can do, but it gives you a little bit of an idea of what it looks like. So there's another, okay, so here we're going to make one. All right. Mr. F, RF, is a pleasant 81-year-old white male. I'm going to kind of go back to this so you can see it a little easier. He came to the clinic, follow up his problem with memory loss, and they had a history physical exam. Chief complaint, he had headaches and problem remembering things, and this is also coming from his significant other. Mr. RF is a right-handed white male with significant past medical history of diabetes and hypertension. He is accompanied by his wife to this appointment. The patient's main complaint is remembering names and displacing things at home. He's getting progressively worse in the last 2 years. He stopped fixing things like working with his checkbook, managing household finances, etc. Mr. RF's wife states that he constantly asks the same question, that has problems with his hygiene. Well, is this also indicative of some early signs of Alzheimer's possibly? But it would take more assessment to actually say that for sure. Noticing problems with his memories 2 years ago after hospitalization for low blood sugar. He also complains of the headaches. He has no known drug allergies. This is his medical information in terms of medications that he was given. Metformin for his diabetes, 1,000 milligrams twice a day, once in the morning, once in the evening. Amlopidine for memory, 10 milligrams every day in the afternoon, once a day. Aspirin, 325 milligrams for his heart condition and possibly to avoid any other heart problems every day, morning, that's more preventive. And he should take that with water. Doxepin is a liquid for his pain management. Takes it orally once a day, usually in the evening because it does cause drowsiness and he likes to drive around. So as long as there's no driving, he could take that. So I put over here some possible symbols that might be used to show what it's for. This will obviously be used for the pain, for doxepin. This is for memory. It's a brain. For amlopathy. How do you pronounce amlopathy? Whatever. Okay. And then this for the aspirin. And we already had one for the diabetes for metformin in the previous card. So what would this look like if you took the time? We don't have to do it now because you could probably figure out how to do that if you ever wanted to with the symbols. But it would look something like this. I didn't put the aspirin on here because, well, I could if I want, but I just didn't have the room. But metformin is a kind of a diamond-shaped pill. It's for the diabetes. You take one in the morning and one in the evening. Okay. And Lodipine is for memory. Take one pill in the afternoon. It's kind of square-shaped. And this might be a little better if you want to do. This was kind of interesting. When I try to make copies of this, it's not as easy as it looks. When I take it out, I'm going to show you what happens when I take it out and try to put it somewhere. I mean, this is fine here. But when I go to the document, and this is one of those things that, it's just a matter of formatting. And so what do you do with all this? So, I could have this. And then when I go to the document, and say I want to paste it. Okay, that works really fine, But then I went over here to the sugar. This thing went a little nuts. All right, it didn't like the sugar. So when I put, let me get rid of this. Well, okay, now this is interesting. Now you know what? Okay, now we're going into different versions. This is Windows 2007, Microsoft Office 2007. I put this on my computer at 2003. You won't believe what happened to this poor chart when I try to put this in it. It won't work. What I had to do up here, I had to go to something that was more like, paste special, and then I had to figure out, okay, so which one is it? Turned out not to be this, but to be the Office Word document object. All right. Again, I mean, not a big deal. It's just, these are those frustrating things to say, I don't want to mess with this. It's too much trouble. But if you have the right tools, you're working with the right version, and you want to play with it a little bit, it could really be a pretty neat chart. So I put in for the memory here, the one pill in the afternoon, and then for the pain, this is kind of interesting. I didn't have anything for liquid. All right? So the pain was no problem. I went on the internet, and I kind of got this little thing here. It's a drop of water falling in, Yeah, and I was trying to find things that may have been, little droplets of rain or something like that, something that would be.
Would you
but,
then take those same
or the spoon.
symbol-
Oh, I'm sorry.
Stop.
I'm sorry, what?
Would you take those same symbols that you put there to remind the person, would you go ahead and make a copy of that and put it on their little pill bottle? Because I'm thinking they're going to go, well, wait a minute, they're going to try to match up, so maybe if they can't read metformin, if you take that little symbol there and do the little symbol in their pill bottle, so they can match, like, oh, that little yellow square goes there, and I should go find my yellow square. If they
Yeah.
can't read the verbiage,
Yeah.
maybe the symbols, so matching, I should go take my yellow square now, or 2 red triangles now, and have a red triangle on that bottle. Do we play with them like that?
I think that would be, I don't know how that would work with making a label as far as on the medication bottle. I'm thinking about the pill box, that says Monday, Tuesday, Wednesday, Thursday, has letters. I don't think there's anything there
There's not.
to be, that you could put the symbols on somehow, And I think it's just a matter that you hope that whatever's going in those little squares, per day is the right thing.
So this is to help
but
them then fill their
those
pill
boxes,
box.
exactly.
So if they don't have a home health coming in. So
Right.
you're saying take 2 pills one morning, did you mean 2 pills in the morning or 2 pills each day.
Take two, I mean this, take two
Yeah.
pills, one in the morning and one in the evening.
See, I would read
Yeah.
it meaning that you want me to take 2 pills in the morning and
And-
2 pills in the evening.
And if you, that's why there's only one pill. But if you had 2 pills in the box, then you would take 2 pills, I think. But yeah, I mean, that's it. Yeah, the other thing is, what this would have to be every day. It doesn't break it down that I do this every other day, say 3 times a week.
Right.
How do you, then that gets a little more complicated. So this is a simplified version. But there are other ways of working with this in terms of it not being a little bit more expanded in terms of whether it's not an everyday medication use. So that's just one, that's a limitation to it right now. But, I mean, I think it has a potential. I thought it was kind of neat when I came across it. And I could send you the Word document for those symbols if you'd like to try those. Okay. All right. All right, how are we doing on time? Oh, we're getting there. All right, so this other thing that I found was on visual communication for photonovellas. You ever hear of those? We use these for culture competency, and they're really good for things that need to be culturally appropriate information. It could be in different languages. It combines, like I said, this knowledge with getting to the principles of health communication. It's like telling a story. It's a poster. And it looks something like that. All right. They're giving this conversation, and it mixes this with, I don't know, I thought everything was good. I don't know what, I mean, is that the kind of gesture that goes on? Here's like, well, I don't understand something. There's something going on here. And like there's obviously some drawbacks here because you got to be able to read. It might be on a low reading level, but if there's a literacy problem, this could be limiting. So you have to really rely on what these pictures are saying. So if you have this, can you describe, in addition to the words, what the pictures are actually saying, right, as a story? All right, so this person is married to somebody who looks like, thank God I'm married. I'll never get HIV. Oh, she's so wrong. Should I tell her? Maybe I'll invite her to my house for coffee. Later in the day, I used to think like you. I had unprotected sex with my husband. Now I have HIV. It won't happen to me because my husband would never cheat on me. He loves me. I thought my husband loved me too. End of story. So this was from a soap opera. Okay. Right, next page. And you see that it's also in Spanish. All right? To be continued. Exactly. So, what's interesting about this is that, you have to have a message that's pretty easy to comprehend through pictures, and that's also pretty limiting. And then you have to be really culturally sensitive in terms of some of the information. And the culture that you're speaking to, you have to be aware of what those culture norms are, okay, to do something like this effectively. I don't know many people that use them, but from my reading, it's like there's some areas in rural communities that use them quite a bit, especially down maybe by the border. I've seen that quite a bit. Okay.
Used a lot for diabetes and heart health.
Right. Mm-hmm. And with the rural programs down here that you're involved in, who develops these? Is this a graphic that you would get?
Some are done by the federal government, the HRSA, NIH. There's quite a lot on, you just go online and you can get all these materials for free.
Mm-hmm.
They will send them to you. They develop quite a bit, and then there's quite a bit developed along the border. There was a lot along the border in multiple languages.
Well, I would like to know is, okay, so how do you know that information's getting through? In terms of them looking at something like this and acting on it, or being more aware of what the issue is here, in this case for HIV.
When are the young
Again.
letting get out of it? I mean, it's like,
Right.
what's her take on it? Okay, so you got a
Yeah.
lousy husband. I mean, she's still not
And-
connecting.
And you find out that
Yeah.
she's got a little bit of education that she needs to go through to understand HIV, quite a bit more. not to mention having, her, this combines speech, some things that we've talked about, and then also the video, the visuals. Obviously DVDs, iPods, there's all kinds of things out there. The thing is, how to get family members involved with this if an older person isn't aware. And I hate that because it's like, there's some really good technologically savvy older people out there.
Right.
Real big time, it just drives me, oh, they won't understand it, they're older, Wrong. I mean, I go to some pachyderm, club meetings, and I'm the one end up learning everything, I mean, it's just amazing. But I think, you can probably question, do these methods work for an individual patient, all right? Or with a family member that could help them, that has not only the technical ability, but has a DVD player or a computer at home or whatever it takes to use it. Lots of web-based alternatives that are packaged to bring out information. Obviously the internet, but I don't know about you, but I'm finding it more difficult to navigate the internet. In terms of getting the right search engines, and then whether the information is reliable and it's not a scam, and then all these little safeguards that you have to be aware of. And I think navigating through it can get pretty complicated. When we're doing our website development here, the very first thing we always think about is, can somebody navigate through this system based on what we have on our website? And we have drop-down menus. How frustrating it could be I just won't mess with it anymore if I got to put my mouse over something and it just doesn't, and it drops down, and then I move it a little bit and it disappears, and I'm like, I need to get it back. So anyway, it's just, and again, maintenance. When we do our websites, it's a big, big deal, and I get this all the time, like, my BioSketch is 3 years outdated. Can you please update it for me? So I got to take care of keeping things current and up to date. Anything else about? I mean, we talked, video conferencing, obviously, but how reliable would this be with getting into a rural community? I'm having, connection problems all the time. I'd like to get to rural clinics and maybe have something hook up there if we could do either some education or some patient interactions. It might be a real worthwhile thing to think about. But I don't know many that actually do that outside of telemedicine. Okay. So telemedicine is the big one for some of this. Okay. So some of the guidelines, I really, really, really push interactive. I think that's really the only way to go as far as not only having it more effective, but a greater chance that they're going to be they're really going to be listening to what I'm saying if I keep things interactive. If I go like not just to talkback is great, but show materials, go through like the pill chart together or whatever. Get on the internet, show them step by step if there's time. And action oriented, what do they have to do? When we have a meeting, we always talk about what are the action items, the tasks. What do we have to do next, right? The material has to focus on the behaviors. Okay, so what is it that they have to do to address the directions that have been given? It's real general stuff. Boing. I didn't know I had this set up like this, nice and slow. So you choose the appropriate meeting. Okay, so you figure out what is it, and I think Sarah talked about this a bit, so I'm just going to do this real quick. What is it that you need to let them know, and who is it that you're talking to? Be very aware of the culture issues, the level of education, who's in that audience that you're talking to, obviously. There are other things that you can use. Multiple modalities is the way to go, that are interactive. Just giving the information verbally just won't work. And what fits the patient needs. There's probably some examples of that. I know with diabetes, there's probably really good visual information out there to show how to manage diabetes. I know like when to give him, what do? They give an orange to give injections, to test how to do that. I think that's amazing. That's pretty effective from what I've heard. Challenges, obviously we talked about access. We have lots of that in East Texas. Desire to get, there's probably some fear, of getting on a computer and getting on the internet, and I'm going to get lost there. Somebody's going to steal my information, my identity theft, everything, plenty. It's all real. Nothing to be taken lightly, And the level of technical skills needed by the patients is real, by the health providers, and not only the patients. Learning curve. What I knew a year ago, technologically, is already outdated. It's antiquated, and so I have to keep up. And so what I do, and you could ask Veronica this over there. I try to get over there to the control center and say, okay, what's new, and what do I have to know? And it's amazing that, people that do this, don't do that all the time. I know this. No, you probably don't. And so for evaluation, that's really important. We really haven't done well with evaluating how the assessment tools, for example, are used for health literacy and measuring that. As far as patient behavior, how do you do that? Follow up. Is it that they're, like Sarah says, they're getting better? They're not getting worse. Maybe their diabetes is being managed a little better, for example. And then when they give you some feedback, how do you react to it? Is it, well, don't worry about it, it's fine, if you're not quite sure? Or if you're not sure and they tell you something, do you look into it to try and answer their questions, especially if you're not sure what the answer is? So just some ideas there. Any other challenges you could think of? There's lots of other things out there to deal with, I think. This is just one.
Time.
Yeah, time is, that should be there. Yeah, that's always.
It's always the
Exactly. Well, I wanted, real quick, this, and I'm really sorry about this. I was trying to put in something here in terms of how to read a nutrition label. I still might try and figure that out. I haven't found anyone that's familiar with the assessment of a nutrition label for different levels of literacy. There's this called the newest vital sign. It's simply just 6 questions that go along to access. It takes about 3 minutes to administer, and I ordered copies of it, and they didn't come in. There's a packet, and it kind of looks like this. And so this is actually in Spanish. So,
would you go back to the address?
Oh, sure. I'm sorry. It's www. I could send this to you if you'd like, but Clear Health Communication. It's in the handout. .com. And it's very hard finding this, as it's copywritten. All right, so I just can't copy it off the internet, and use it. And the ones I saw were kind of, I couldn't even take them off the internet. They wouldn't allow me to copy. So I did this. I did, shift print screen.
Right.
And that's how I got this copy, because I couldn't save it to do anything. But what it does, if anybody knows Spanish, I didn't have time
Still working on English.
to translate these. But I have a feeling that what you're doing is you're looking at this and asking questions regarding what is going on here that you need to know in terms of
It's an ice
this.
cream label.
Right.
There's either read it to the
You know.
patient.
Uh-huh.
It's on the back side of an ice cream label, and it says,
The whole container,
Yeah.
how many calories?
would you have consumed?
Yeah. Per serving.
Per serving. Right. Okay.
No, it says.
No, if you eat
ate
the whole
Not per
thing,
serving?
1,000 calories.
That's not So that you can.
So that's,
see-
okay, so that's the
check
answer.
That they understand how many servings are in
Uh-huh.
there
And-
and how many calories.
And something is 33 grams. So somewhere in
That's if you
here.
ate the whole
Time,
thing,
times four,
maybe?
something times four is
Yeah.
33.
Okay.
They're saying if you normally eat 2,500 calories in a day, what percentage of your daily value of calories would you
Would you
have
consume?
consumed with this portion?
Wow.
Wow, yeah,
So I guess you're adding up.
that's high level.
Can they understand the question?
Yeah,
Yeah.
exactly. You know, I don't know how, you know, I gotta admit, I go to the store, I don't look at nutrition labels a whole lot. But I think out of all this, I think what the most important one is the sodium.
Uh-huh.
That's the one that always gets me.
Depends on what
So,
you're
but
trying to accomplish.
Yeah,
If it's
it's
cholesterol,
Right.
if it's weight loss, it's
Yeah.
protein.
But you also need to
fiber.
understand the normal, sodium. Like it says 55 milligram. What does it tell you?
right, a lot of these should be giving like minimum daily amount, percentage, you know, percentage per daily
I
consumption.
think that's what it's saying
You know.
there, percentage daily values based on 2,000 calorie diet.
Uh-huh.
So it's kind of giving you this is what this is based on, the 2% for sodium.
Okay. Wow. Well, for me, I'm not interested in weight loss. So I might be more interested in, yeah, can I get high calorie? I'm looking at high calorie. Fat.
Well, they're asking
Yeah.
about saturated fat.
Mm-hmm.
It's a bad fat. But they're asking them to do calculations,
Right.
which are a bit complicated.
Yeah.
Right.
Well, and if you look at for instance, the 40%, where they're talking about saturated fat, 9 grams, that's, just
Uh-huh.
basically off the top of the head, that's a lot. So that's 40% of your daily allowance. If you do 2,000 calories a day, you've already had 40% of your saturated fat just in one serving of what that item is right there.
Right.
Mhm. Ice cream.
See, I think the nutrition. I'm sorry.
So,
Go ahead.
no, I mean, that's
Right.
just, okay, that's good, but that's half of what you're gonna get for the whole day.
So if you have, okay, so for one serving, 250 calories, you're already getting 40% of your saturated.
And that's a half.
Fat.
a
And remember,
And
that's
that's-
2,000
That's one
calories, so
half
like
of
for a
the
woman,
half of
depending upon size and weight and height and all that, if you're trying to lose some weight, you wanna be somewhere between 1,600 and 1,800 calories approximately, depending upon how active you are.
Right.
So there's a lot of factors that go into that.
Uh-huh.
But at 2,000, if you eat 2,000 every day, and an average sized woman, quote unquote, you're probably not gonna lose much. So then you have to take that into account as well.
Wow.
Yeah.
Well, I wonder what this was. Cream, skim milk.
It was ice cream.
It's ice cream?
So it's
Oh,
included
okay.
in this,
With
And
the
it-
sugar water, egg yolks, brown sugar.
Yeah.
And then it says,
It's
yeah, it
good
says
ice
if you're
cream,
allergic
too.
to penicillin, peanuts,
That
latex,
first ingredient.
and
Not
beef
too bad.
sticks, can you eat this? Or
Ah.
is it safe to eat? And you're supposed to say no because it's got peanut oil.
Right.
Oh, you're good.
Yeah. That's right here.
Yeah. Well, if there's no.
Well, yeah, I'm sorry I didn't quite get. Thank you for helping. It really is. I mean, I think that this is something that could be really useful, and I'll try to get more information on that.
A good one of that, Tony, is
Mhm.
go to the diabetic website because they talk
Mhm.
about how many carbs, how many fibers, how many this and that you need every day.
Right.
And how it has to be well-rounded, and you probably find everything just in one
That's a good
nutshell.
thought.
And what it means.
That's
right?
really good.
Exactly, yeah.
People don't all know what that
Yeah,
would
what a
mean.
carb
what it
means.
means.
And we have a dietitian pretty much on, right, Patty? On in the ACE unit, do they get diet information consult? Most clinics, I guess, do have access, to dietitian information. Because I think it's real crucial stuff, and whether or not they could understand what all this means, that's pretty high level. Yeah. Does anybody at the other sites have anything that they want to ask or contribute, especially to the nutrition newest vital sign here? Somebody was asking about whether or not that would be presented today, which is why I put this in here. But again, I apologize for not really having that much information about it, but I think we, with the help of everybody here, covered it pretty well.